Well, we'll give about 2 to 3 more minutes for folks to join. Ben, glad to see you're back from vacation or week off. I'm sure you're swamped with 10,000 emails upon your return.
Thank you. I don't know if I share in your sentiment of being glad I'm back, but I'm here.
Well, I'm glad you're back, and I'm sure I sent you about 800 of those 1,000 emails. So thanks. And Joel, today is the meeting where you have to exit early. Am I remembering that right? Okay, good.
Yes.
Great. And Ricardo Contreras has an excused absence this evening, Paula. So he has family vacation this week. Okay. Well, I will go ahead and pull something up as people join. There we go. And Peggy, thank you for starting the meeting.
Me too.
Yeah, well, they're consolidating Zoom stuff at the county, so I think I can still log in, but nobody's positive about that since it's a CSC account. And so I'm going to shift to a Teams meeting link for this. And I think if it's a Teams link, people can click on it even if I'm not there. Am I right about that with Teams? Yeah. I learned that yesterday when Rebecca, you had made a meeting and generated the Teams link, and then you couldn't be there. And I clicked on it and we all could meet without you. And I was like, oh, the genius of that for team meetings. Thank you.
You can do it with Zoom, but you have to go into like the web Zoom portal to set up that setting to allow others to join without you. But Teams I like. I didn't like it at first, but I use it at work and it's kind of growing on me.
We do so much cross organizational work with city, county, CSC providers, a contractor for grant writing, and we need to share documents and edit them. And instead of multiple emails back and forth and version control, this way we can host documents together and have group chats and have different, folders, and they call them channels. And it's a little different than Google and that kind of functionality. So it's really nice. Hey, Anita. Oh, good. Charissa's here. Charissa, I know that you are presenting tonight. Do you want to go ahead and test out any screen sharing before we get started, just to make sure everything's good?
Sure. One sec. I didn't have it open yet because I know we are late in the agenda, so
that's okay. Take your time. I'm just giving another minute or so for board members to join until we have a quorum here. And 3 just joined, so we're at a quorum. Yep, you got it. That looks beautiful.
Okay.
Yeah.
Great.
Thank you. You can go ahead and stop sharing. Perfect. All right, we have a quorum. Yes, it's a beautiful slideshow. We have a quorum. Oh, Johanna, is this your last H.O.P.E Advisory Board meeting? Would you like to share an update with folks?
Yes, thank you. My computer is acting all weird, not getting me access. So yes, hello everyone. My name is Johan. I am the EDI coordinator for Benton County, and next Monday is my last day with the county. I'll be moving up to Bellingham, Washington, to serve as Western Washington University's next LGBTQ+ director. So this is my last meeting with you all, and just wanted to say thank you for all your wonderful work. You're doing amazing work for the county. I really appreciate everything that you've done, and it's been an honor to be able to listen in on your meetings and watch your recordings to the ones I couldn't meet, and just hear all the wonderful work that you've been doing. And since I started this position, some wonderful progress has happened. I know more work will continue. we're actively searching for the next EDI coordinator. So if that's something you're interested in or know someone who may be interested, please let them know. The priority deadline is August 9th. So we are still seeking applicants for that. And we're open for anyone to apply. So thank you for sending that information, and I can send it to Julie so she can send it out to you all if you'd like. So thanks for having me. And thanks, Julie, for giving me time to send a message to everybody.
Absolutely. Johan was the first person as an equity, diversity, and inclusion coordinator with Benton County. It was a new position, and they have paved the way and laid a foundation that the next person who fills that role really will be able to stand on the shoulders of fantastic work. So thank you, Johan.
How very exciting for you.
Yes, congrats to you. I hope you love it up there.
We're so excited to move up there. Yeah.
All right, folks, we have a quorum today, so I'm going to go ahead and start your July Hope Advisory Board meeting. And we'll get through some logistics in the beginning with Zoom housekeeping. You should be muted, but you can unmute. If you want to make a public comment, please type into the chat area and say your name and what you'd like to make a public comment about. And I'll also give an opportunity if anybody has called in on the phone. We will do public comment right after we review the meeting agenda to give people time to enter into the chat. After public comment, we'll do roll call on approving your meeting minutes from last month, which I sent out on, I think, Friday of last week. Tonight we have Kaylee Olson, our Health Department Communications Coordinator, with us to provide a Hope Communications update, because there has been a lot of fantastic progress on that topic. And it really was inspired by your Hope recommendations and includes quite a bit of content on those. And then we have our project manager, Rebecca Taylor, here this evening, and she and I are going to give an update on the House Bill 4123 pilot for improved coordinated homeless response in Benton County with the city of Corvallis. And then we have a fantastic educational component for you tonight. We have three folks joining us: Melissa Zavorin, who's one of your fellow board members, Paulina Kaiser, who's the director of the new Research Institute at Samaritan, and Charissa Young-White, who's their Medicaid engagement manager. And they're going to be talking about, what does IHN-CCO do? Intercommunity Health Network Care Coordination, Coordinated Care Organization. I'm sorry, I should know that by heart. And Samaritan Health Plans, what role do they play? And this is really important for Hope implementation efforts, because they are a key community partner who's going to be working on improved care coordination and sustainable funding. And those are two of your Hope recommendations. So understanding the role that they'll play is real key. Just a reminder about the agreements that you all wanted to make for your culture of conduct as Hope Advisory Board members. This is going to be 3 years old this fall. I can't believe it. But kindness and inclusivity and curiosity and open-mindedness are some that got checked a couple times. Okay,
Really?
Sorry, go ahead, Charles.
Every time you share that, it's just like, wow, we were in person there when we did that. And how long ago was that? You know, it's like, so I always appreciate the image just because it's like a flashback. It's great.
Writing on whiteboards with a group of people. That's my jam. I can't wait to get back to it too.
Right.
All right, I'm looking in the chat and I see fantastic acknowledgements for Johan and Bellingham, but I do not see anything as far as public comment. So I'm going to go ahead and stop sharing and see if we have anyone who is called in on the phone. Seeing none. All right, speak now or forever hold your peace, folks, for public comment. Okay, I'll go ahead and screen share just for one more minute to do your June meeting minutes. I sent them out. I received no edits or changes from any of our board members. So we need, does anyone want to make any edits to the minutes right now? All right, then we will need a motion to approve them and a second.
Motion to approve.
I'll
Thank you,
second.
Brian. Thank you, Peggy. Paula, did you catch that, Brian and Peggy? Okay. Catherine Bisco, do you approve the minutes? Are you here tonight?
I am here and I approve.
Thank you. Carol Butcher.
I don't recall letting her in, Julie. I don't see her.
Okay, thank you. Ricardo has an excused absence this month. Brian.
Sorry, say it again. I got interrupted.
Oh, we're just approving the meeting minutes from last month. I received no edits from any board members. Do you approve them?
Yeah, I'm approving them here.
Thank you. Cade.
Here and approve.
Thanks. Anita.
All good, here and approve.
Joel.
Here and approved.
George.
Here and approved.
Ari.
I don't recall letting Ari in either.
Okay, thank you. Barbara.
Here and approved.
Melissa. Melissa might be a little delayed today, but I know that she will be
I just
attending.
let her in, so she might be just getting audio.
I am here, thanks, hello.
Yay, good. And you were here last month too, Melissa? Do I have that
I
right?
was,
Okay, you can vote on the minutes then.
thank you.
Do you approve them or no, or abstain?
Oh, we're on minutes, thank you. I'm sorry I was late. Yes, approved.
Thank you. Bria, I don't believe she's here this evening.
I don't recall seeing Bria come in either.
Thank you. Cindy.
Present and approved.
Charles.
Present and approved.
Charles, were you able to attend last month? I think you were very ill.
Is that the one I missed, or was it the executive meeting I missed? That's what
I
was trying to
don't
figure out.
remember anymore, friend.
Well, I read the minutes and it said I was there, so I assume I was there.
There we go. We'll take your
And it-
approval.
And it all sounded
Apologies.
familiar, so.
Apologies. Peggy.
Here and approve.
Andrea.
Here and approve.
Jan.
Here and approve the minutes with honor.
Chanel.
I don't recall Chanel coming in.
Reese.
I'm here and approve.
Nancy.
I am here, but I do not recall if I read the minutes or not, so I'm going to abstain.
No problem. They pass with plenty quorum. Okay, so moving on to the communications update. Kaylee, do you want me to leave this slide up or do you have something else you would rather share to give a visual representation of these comms?
Yeah, I can share my screen so I can walk folks through where they can find all of this great new information.
Do you want to talk through any of these bullets before you screen share, or should I just take this down?
Yeah, sure. Why don't I do that? So we wanted to share a couple documents with you today. One is a 2-page list of all of the HOPE recommendations. And so the hope here was to provide something that is easier for folks who don't know about the HOPE recommendations to read through, to understand, than the entire wonderful 17-page document full of comprehensive information about all of the details that you all poured into this wonderful work. But this document will allow, it's 1 page front and back, so it can be printed, it can be shared, it can be linked, and I'll show you that here soon. The update you're seeing there, let's see, there's a new web page. It's a HOPE recommendations and community progress page. And then also kind of accompanying that web page is a community progress report that lists that same information in a 3-page document. Again, easy reading, sharing, printing, all of that. A press release just went out regarding our awarding of funding for the Coordinated Homeless Response Office support. And then we also finally launched our, what you would call sort of a newsletter. It is our news and updates email list, which is going to feature routine updates and communications and news and information as it becomes available. So I'm going to go ahead and walk you through all of that today. The first thing I'm going to start with is some of the edits to our webpage. So let me screen share here so you can see that.
And can I just chime in and ask Kaylee, do you want questions about these as you go through them, or at the end after you've covered them all?
Thanks, Julie, for asking. Yeah, let's go ahead and save them to the end, because I may address something that comes up for you in the multiple different platforms that this has gone out through. So let me get my screen going there. Okay, can everyone see that okay?
Yes, it looks great, Kaylee. Is that big enough for our board members? Folks seeing that? I'm seeing nodding heads. Okay,
Looks good
thanks,
to me.
Kaylee.
All good.
All good. Okay, I will proceed. All right. So on our Benton County Hope web page, we've made a couple new additions, a couple changes. So, you'll see our normal Hope advisory board information. You can still contact Julie through this link. We have our new subscribe link to our new Hope News and Updates email list. So if you click that link, you're taken to a sign up form here where folks can enter their email address and information to sign up for the email list. So going back to that housing page, we also have a new Hope Recommendations and Community Progress webpage, which I'll walk you through here in a second. But first, I just also wanted to note, we were able to create a separate web page here for our Hope meeting information. And so you'll click that link and you'll find the same information that was always listed here on the website about how to join the meetings and past meeting materials. It's just now in an easier to find place where you don't have to now scroll through all of this information about meetings to get to our governing documents and information. So there will likely be some future web updates, helped coordinated through our health department admin assistant, just to continue providing more easier, accessible and a prettier formatted sort of web updates. So more to come there, but for now, I'll walk you through our Hope recommendations and community progress. So you'll see here just a brief overview of what the Hope Advisory Board is, what they do. You'll see here a link to the full 17-page document. I'll open it here. This is the recommendations you all came up with back in spring 2021. And then below that is this lovely 2-page recommendations document that I mentioned earlier. So I will show that. Sorry, my little Zoom bar is getting in the way of this. So let me move that over. Okay. So let me zoom in here as well. This is our 2-pager. Again, a brief intro about what the Hope Advisory Board is. There's also a link to that full recommendations document there. So while we want this to be easier reading for people who just need a quick overview, we have that here, but we know that some folks want that deeper dive. So that's where they can link back to that full comprehensive document. Then we've got our foundational recommendations. And so each recommendation has sort of a brief title explaining what it is. We know these are very complex and there's so much more information to learn, but just to, again, facilitate that easier reading for folks who are new to this. And so we've got a brief description of what each item is. And then below the foundational recommendations, you'll see our 12 policy recommendations. Those go on to the next page, and then you'll just scroll down and see all 12 of those recommendations. And then at the very bottom, we have a link back to the main Hope page. So that is the recommendations document. And then back on the page, the Hope recommendations and community progress page, we organized the progress made by all of our network of providers and government agencies that are involved in this coordinated homelessness response work. So you'll see updates from our homeless service providers work. You'll find updates from the city, the county, and all of this is organized within each recommendation. So I'll take you first to the community progress report, which is the same information in a condensed version. So that is here, and I'll zoom in again. So this is our community progress report. Again, a brief overview of what the Hope Advisory Board is. Folks can also click a link here to go back to the Hope main page and learn a little more about Hope there. And then we've got a little brief explanation of, the acceptance of the recommendations, and then the document describing that this is a list of progress over the last year or so made by the community. So again, link to our Hope page, and then we'll go into our, and I should have mentioned here, we've got a link with the recommendations to the shorter document as well, so that folks can find that abbreviated version. Let me zoom in here. And so again, organized by recommendation. So 3 foundational. We've got little images to kind of help capture what the recommendation is about. Each of the recommendations has their title is a link. So you can learn even more than you see here in this box on that recommendations and progress web page I talked about. So if you click organizational capacity, you'll be taken to the web page for the progress on the organizational capacity recommendation. So when you see it here, it's abbreviated because we just have so much amazing progress that we can't fit it all in these little small boxes. And so we recognize that, you know, not everyone knows what city or county or CHF or OHCS is. And so what we've done is we've allowed a link to go back to the full explanation of each progress item, but also a link to those web pages. So what do you mean by city? I'm not from Benton County. Are you talking about Philomath, Corvallis? What are you talking about, right? So you can go to city and you'll be taken to Corvallis, Oregon's homepage there. And then similar with, you know, what regional bias response initiative, what's that? You can click that link and find out more about that initiative. Right, so we just wanted to provide one-stop shop where you can find everything and then allow links to deeper dives if you need the more information. So those are the foundational recommendations. We'll also go into the 12 policy recommendations. And as you can see here under recommendation number 3, the care coordination, even when we abbreviate all this stuff, there's still just too much great progress to list under there. And so you can click learn more, which will take you to the same link that this care coordination links you to. And that's just the web page recommendation progress that we spoke of earlier. So that is the document there. And again, you'll see all the rest of the wonderful recommendations. There's another learn more link. We go into resource center, barrier reducing communication.
Haley, can I hop in for 1 second just to make something real clear for folks joining us tonight? This is organized by the 12 HOPE recommendations, but this includes progress that a bunch of community partners have made all on their own. And so there's stuff in here that the city has done or the county has done or that we've collaborated on or supported. And there's also stuff in here that's highlighting the fantastic work that so many different organizations are doing on their own and in collaboration, and really wanting to showcase to anyone in the community that when our service providers are adding capacity or expanding services, that the city and the county support that work and it falls into the HOPE recommendations. So this is accepted and backed by the city and the county.
Yeah, thanks for that explanation, Julie. And we really wanted this document to highlight that work and those providers, because we all know in this group that this is not work that the city and county are doing. This is a work that a network of us are all contributing to make this happen. And that was another idea for the links, is to sort of provide more of that visibility to some of our providers to highlight. So you'll see, for example, here's JSYS, that's Jackson Street Youth Services. So if you click on that, you'll be taken over to their page. So again, you know, creating more visibility and reach and engagement for those organizations as well. So thank you, Julie. And that is the community progress report, print it, share it. We also, back to that main community progress and recommendations webpage, just wanted to show you a little bit more about each of those recommendations. Again, stopped with the foundational recommendations and then going into, you know, our data improvement program metrics, care coordination, all with a little graphic image to kind of help you understand that recommendation. So I'll give you an example here, crisis response. This describes, again, the recommendation, a little bit more info about, you know, what's behind that recommendation. You again can link to the larger 17-page document to find out more details about that. And then when you finish reading through the progress, you can be taken right back to that main recommendations page to see the rest of them. So
And I am so bummed that Carol is not here tonight because she is the one who has been asking us for exactly this for months. So boy, I'm going to reach out to her
she'll
specifically.
have to watch the recording. Okay, so I'm sure there's questions about that. I'm happy to answer. And right before I get to that, I just want to make sure we share about our lovely new e-news that that came out a couple Fridays ago now. Let me zoom in here on this one. Is that big enough?
A little bit bigger would be helpful.
What's that?
Good. No, that's good.
Is that
Thank
too
you.
big? So just an intro about, why we're starting this newsletter. It ties directly into HOPE recommendation number 9 about communicating regularly about progress and updates. And then you can link back to our HOPE webpage for more information. Julie's going to talk a little bit more about our coordinated homelessness response initiative and the funding for that and the press release that went out. You can see the full news release there. Again, we're highlighting that 2-page document so that, someone new to this newsletter can understand what the recommendations that we're talking about are, and then find the progress report where you can learn what has been done to support those recommendations. And then here's just a news piece that we'd like to feature. We can, use this platform to announce new information about housing and homelessness services and updates and resources for community members and community partners who work with our community members surrounding housing and homelessness issues. And then finally, just some contact information at the bottom and our Facebook link there. So that
And
is the
folks
newsletter.
can sign up to receive this back on the main HOPE landing page. Would
Yep.
you show that, Kaylee?
Yeah, absolutely. So here's the top of the page. You'll see the HOPE intro here. The second link from that paragraph is subscribe to HOPE news and updates. If you click that, again, this is the landing page that you'll see to subscribe. So. Oh, and then before I, here, let me go ahead and stop sharing my screen. Just a little bar.
Sometimes it hides from me as well.
I'm glad it's not just me. Okay, great. There we go.
Haley, I hope you get to see all the comments in the chat. Really commending you for this fantastic body of work. I know folks have been waiting for it for a while, but it takes a really long time to build out a website and get approval from, 20, 30, 40 different organizations and providers about what they'd like to share. So this took the time that it took so that it was done thoroughly and with buy-in from a lot of different folks.
Well, thank you all. I appreciate that. And I just also wanted to give you a brief overview of where this information went out to. So we posted on our county health department Facebook page about this. And then that was shared out through our county main page, as well as our city main Facebook page. And then the county main website has a nice banner where you can click it and link directly to that progress report. That news and updates email I just shared with you has all of that, links to subscribe to it, links to the progress report, all of that good stuff. Obviously, you saw the HOPE web changes. And then the county has an external e-newsletter that they send out monthly to the public. So there was a blurb in there about it, as well as an internal newsletter to county staff. It was featured in there. We also emailed some key service providers to make sure they were aware of the communications going out. Obviously, as Julie mentioned, there were meetings devoted to their input on the community progress document. So they knew it was coming out, but we let them know it was finally released. And then finally, so our HOPE team did some updates at some city and county elected official meetings recently, and there was some information about this listed there. So just wanted to make sure you were aware of all the platforms that went out, and I will take your questions, comments, concerns.
One more thing, Kaylee, I want to thank our HOPE Advisory Board members who met with Kaylee as part of the communications work group to give feedback on all the different ways that this could be shared throughout the county. county, because that did help inform some of these outreach efforts. So thank you for your input on that. And I see George. Oh, George, go ahead and unmute yourself, please.
There we go. Now, can you hear me?
We can go for it.
All right. Thank you. I appreciate that, and I echo the comments that are in the chat as well. You answered part of my question. The other thing I wondered was any media outreach. There's, this is something that's pretty big, and we've heard from different media sources in the past about, gee, what's Hope doing lately? We haven't heard from you lately. So here's a good way to make that connection. The other thing that comes to mind as I see this is that the word that comes to mind about this is transparency. It makes it eminently transparent. And in that effort, one of the things that I noticed, and it's always kind of frustrating, is our minutes are always 2 months behind. They're always way behind because we wait until we approve them. And I'm wondering, is there any reason why we just can't post them as draft minutes on a piece of paper that says draft? And then post them both. I mean, that would just give people current information when the minutes are ready to put them out there, and they know they're drafted. They could say all kinds of disclaimers subject to approval at the next meeting. I mean, any of those kind of things. But it would be nice to be able to be, in terms of being transparent and getting current information about what we're doing, to say here it is.
George, I'll follow up with our county council, and also Paula supports note taking for a variety of different meetings. So it's also her time to be able to go back and edit from her shorthand. So whatever is possible, we will try to do.
Right. Well, we get draft minutes before we see the draft minutes before they come out, and so that she's finished them by that time. So if they got posted even when she sent them out to us prior to the meeting, so we can go over them, that's still sooner than waiting until after another month our meeting goes by, and then it gets translated after that, and to get it out sooner.
That's good feedback, George, and I'll see what might be possible for a sooner posting of draft. To answer your question about media outreach, I want to read something from the chat from Cody Mann, who's here from the Gazette Times. The Hope team gave him an interview on this subject, and he's working on a sizable article right now. It was Kaylee Olson, Patrick Rollins, the public information officer from the city, myself, and Brigida from the city as well, who met with Cody. Gosh, it was about an hour and a half on a Friday afternoon. It was a long interview. So we are doing our best to engage with the media to make sure this is covered too, George.
Yeah, and in addition to that, the press release that went out, it was related to the Coordinated Homelessness Response Office, but it did allow folks a link to subscribe to the news and updates, and it also featured a link to the community progress report, I believe. And so we sent those materials to Cody Mann as well from the GT and that interview. And then I just wanted to note, Julie, on the minutes being transparent and available a little earlier. One additional thing, George, is that the video does get uploaded, the recording of the meeting, within a couple weeks, I want to say, after the meeting. So a lot sooner than that.
It is way sooner than that. So I download it tomorrow. I let our support staff know on Friday or Monday. It takes a while to upload to YouTube, but the video is usually up within 1 week, by the following Wednesday when the approved minutes are posted as well. So video's real quick. Melissa, go for it.
Yeah, just a consideration on the minutes, because I have partaken in many public groups before, and sometimes notes can say things out of context. And so as long as we all agree that that's not a concern, and the minutes are just usually approved as is, then it's probably not a concern. But just making note of that, because I've seen that happen several times.
I have too, and Paula does an exceptional job of providing a lot of context for everyone's comments. Really a dialogue almost of everything that happened. So I hear you. Any other comments or questions on this topic of communications? I know for many of you, it's been a long time coming and you're really excited to see it. And it's something that you've wanted and recommended for over a year now. And this is where a dedicated staff person, it's only half of Kaylee's time because she has to do communications for the whole rest of the health department, but half of her staff time gets to be spent on this. And without her, without that dedicated staff person, it's not possible to have great communications like this. Okay. Any other things you wanted to add, Kaylee?
Just thanks everyone for allowing me this time to walk through everything with you. I'm really excited. I'm able to support the wonderful work you've all been doing. And yeah, I'm just excited to keep moving forward with this. So thank you so much and look forward to continuing.
Kaylee, can I ask you to screen share one more time to pull up the press release as an intro to what Rebecca and I are going to talk about?
Sure, yeah, 1 second. Let me grab that for you.
Since you already have it up, but if you don't, I can pull it up.
I have it real quickly clickable. So let me grab that here and let me share my screen.
This is another example of the work that Kaylee does. She put together this press release, which also needed to have quite a few eyes on to approve before we could release it. And it's hosted on the HOPE website and it was sent out to media outlets. Yeah, there we go. If you can scroll down just a little bit, Kaylee, sorry, this was released a couple weeks ago, and really just trying to answer questions that we have kept, hearing, and questions we receive about, well, what are you doing? What is this pilot? What's being done? And what do you plan to do? So this is really helpful if you get questions like this as well, to be able to link folks to this. And there is a link to this in that email that I sent out last week to you all with all of the communications. George, you crack me up. You can stop screen sharing, Kaylee, and I'll go ahead and dive into this content with Rebecca. Any other questions on comms? Okay, then. Thank you, Kaylee, for being here. I don't think you have to stay for the rest of it, but you, of course, are always welcome to. All right. So, coordinated homeless response in Benton County and the city of Corvallis. I have shared with you before that House Bill 4123 passed in the short session, and it is providing funding to Benton County and the city of Corvallis to improve and work on how we coordinate our response to homelessness with each other, with community partners. And it's giving some funding over the next 2 years and has quite a few requirements outlined. One of the requirements is to create a 5-year strategic plan that's due next summer in 1 year. And that strategic plan must include, or at least touch upon, and have ideas for sustainable funding for homeless response and services. And that's really where the educational component from IHN is so key to understand how vital it is to coordinate with all of our key community partners to figure out things like sustainable funding and strategic planning. Okay, so Rebecca, do you want me to pass this off to you? And would you like to introduce yourself for anyone who hasn't met you yet?
Yeah, I'm Rebecca Taylor. I was recently hired as the project manager to assist with this work that's been ongoing. I'm happy to be here, and I am jumping in the deep end, helping out with the House Bill 4123 implementation. So I could, Julie, if you'd like, just to kind of say where we're at as far as the progress on this. I know that we've, as Julie said, we've talked about this project with you for some time now. So right now, we have been using some of the groups that we have set up for other HOPE implementation to discuss this project and create a roadmap essentially moving forward to address some of the requirements in the House Bill 4123. So at this time, we are closing in on developing final draft language for our Memorandum of Understanding at this point for a group, or what I would call a collaborative framework for the preliminary House Bill implementation. So right now, as a local interpretation we have of the legislation is that the Memorandum of Understanding is an agreement of the different members, which we have identified the city and the county as these initial members for the preliminary implementation of those requirements. So in that work, this group will be working with our service providers and many of the other community members to really understand how to form this office and what that looks like locally. We recently met last month with the League of Cities and the Association of Counties with the other pilot communities, and learned about kind of how they're going to do a local implementation. It was pretty exciting to hear where Benton County was as far as the work we've done locally on this topic and where we're at with information. We will definitely be a resource for these other communities as they work to implement it. We actually have a meeting this Friday, again, with the other pilot communities to see where we've gone in this last month. And so I think at this point, we know the Memorandum of Understanding is due October 1st. So at our joint elected officials meeting in September, we will come with a draft of that Memorandum of Understanding and with a little bit more information as far as different decision points about potential organization and functions of that office moving forward, and also a plan about how to develop that strategic plan moving forward. I hope I covered everything you hope for me to cover, Julie, but let me know if you'd like me to touch on anything else.
No, that was perfect. We really want to make sure at the city and the county that the role that this coordinated homeless response office plays is something that our providers want and need. And so we've asked the question last week and again this week, what role and function do our providers who are out there helping people in need from us? And so we are putting that together and documenting it. We've gotten some great feedback from our local providers and want to make sure that they feel included and like they have been a part of the formation of this office and what it does and how it collaborates with them to improve our whole system. And so we're really taking the time to do that very thoughtfully and deliberately. George, go for it.
Well, thank you. We've recently had a conversation about in a presentation on City of Corvallis social service funds. And when I see a word like sustainable attached to things like this, what that tells me is one of the things they're looking at is how are you going to fund this over the long term and how are you going to make it happen? And one of the things I just wanted to throw out there is part of what this group does is look at those kind of things and make those recommendations. The city right now has a pot of money that's attached to tax dollars that comes to them every year in the form of that social service fund. And I'm not suggesting they do this now, but they do have it within their authority to say, in terms of making this center sustainable, we could utilize those funds for that particular purpose. And so there are decisions that can be made, and that would be one of the decisions that would be on the decision point. Another thing would be for the county to look at similar resources to be able to say, let's make a commitment up front. That's to say we can put this much into the pot to get it started. Once we get an idea about what this would cost, it's going to take some time to figure out what you're looking at and what the actual services will be, but what the actual cost is going to be. But there are options to make this sustainable, and we have to be willing to look at those things and make those recommendations to support the elected officials that have to come up with these ideas. But where they're going to get them is from places like this.
And also, this is the key function of the grant writer that the county has contracted with to help figure out sustainable funding, because it's not just sustainable funding to coordinate homeless response, it's also sustainable funding for the system of services and sheltering that right now so many of our providers are, grant cycle to grant cycle. How do we make sure they can hire full-time sustainable staffing? That's where IHN's role in funding for traditional health workers is so key. And it's also where our grant writer looking at funding streams that perhaps the county has never tapped into before, but that are available, and putting together a guidebook of grant funding so that we can have that capacity going forward to draw down funds sustainably that we haven't tapped into yet.
I don't disagree with any of that. That's all true. But when I see words like sustainable, the only source of sustainable funding in local government is tax dollars, period. End of story. There's just really nothing else. And so when you're talking about grants and grant writing, that's not sustainable because funders will fund that for a while and it's based on what other governments may do at that particular time. So, that's why I say we need to leave that on the table and have that out there and acknowledge that. I mean, that's an acknowledgement that I think that needs to be made so everybody understands. If you truly want something to be sustainable, communities have to commit to pay for it. And the way they commit to pay for it is through taxes.
I want to push back a little bit, although I agree with what you're saying, George. Medicaid is a sustainable funding stream for services. And there's
it's tax dollars.
True, but not the local, pot
It's-
of
it's-
social
there's
services.
there's no money in government other than tax dollars.
All right, thanks, George. Carol, go for it. Welcome to the meeting. I haven't seen you yet. Good to see you.
That's because I forgot about it. I remember
Thanks.
it's hard to believe, but it's true. 2 questions. Well, in terms of George's comments, of course I disagree, and so we can deal with that later, because there are some grant-funded programs that have been going on forever, and there have been city-funded programs that have been cut. So it's a crapshoot. But that's not my point. The list of service providers, is there a list? I bring that up because a couple of times when I've been at other meetings and I've said, the service providers, somebody will say, well, nobody contacted me. And I did, and particularly in this one situation, it was Soup Kitchen saying that, we hadn't been contacted. So I didn't know how broad that net was.
That's a good question, Carol. There's different networks. When we're talking about providing sheltering to folks experiencing homelessness, I wouldn't be engaging folks who do a warm meal each day. But then we also have Matt Gillespie, who's on our Healthy Communities team, who engages with all of the food provider network. And whenever we have sort of a general update for outreach, Mac is the one who sends out the contact, because it includes all of our food providers and all of our folks working in sheltering and housing and homelessness. So we do our best not to overwhelm people's inboxes if it just really doesn't relate to their organization, but also to be as inclusive as possible when we're asking for feedback or input.
Okay. Thank you.
Yeah. And Paula, can you note that Carol is here and Bria is here as well? Thank you. Other questions from folks about this pilot that we are embarking on? Oh, Carol, I forgot to answer your question about the list of service providers, aside from like input and updates and feedback. HOAC and many of my predecessors did a fantastic job of putting together a very comprehensive list of all the different service providers across the spectrum. And then you all as a HOPE board really looked very closely at what do we have, who are the providers, and where are the gaps in our system. And so one of the functions that might come out of this coordinated homeless response office is to map out our services system and who are all the providers who provide what services along that system. What are the pathways for referrals between them? And so that might be a function of this coordinated office, but we're still working to make sure that that's something that our community and providers want from us. And Andrea, you are here tonight. You have been involved in these meetings from the provider perspective. Is there anything to add based on your experience in engaging with this?
Nope, I'm good. And I think, we've spent a lot of time trying to reach out to partners, and but I think that the focus groups that we have that we're talking with are appropriate. The only thing is we have some other shelter providers in the community, but they serve such specific populations that it's hard to, it's kind of like they already have down what they're doing. So whereas it's more unclear with the adult population that aren't DV victims or youth.
And I'm always sure to reach out to Anne and Kate to make sure they know what's going on, and they provided updates for that progress report too. Andrea, would you like to provide an update on Project Turnkey 2.0? Because it is an example of sort of the coordination of city, county staff in support of system improvements.
Sure. So we, for better or worse, sometimes be careful what you wish for. but it's really exciting. The legislature has given Oregon Community Foundation another 55 million to put towards purchasing more hotels and motels across the state for the purpose of shelter and housing for people experiencing homelessness. We have worked with partners, a variety of partners to put together a proposal for the first phase. So there's two phases of the proposal process. The first phase is really just the conceptual design and the program design and the partnerships that we have formed so far in interest in purchasing another property. And it was really great. Like I really appreciated the process when we talk about capacity building for organizations and how, the role of H.O.P.E and some of the staff, what they can do. We were able to submit an application as the owner operator with 12 letters of support from various partners, as well as, really solid proposal because it was a joint project with H.O.P.E staff, with Libby and Julie. So I appreciated all that help so much because there's no way we could have done it. Basically, the gist of our idea is that we would purchase a second property. We have in mind which one we'd want to purchase, but we don't have any kind of sales agreement or anything in place, so I don't want to say where it is, but targeting older people that are experiencing homelessness and respite care. So working with Samaritan on providing more respite beds for people, as well as senior disability services, CSC. I'm like blanking now, like the county, COI is a partner in this, and vet services. So targeting some vets as well. With the idea that we would open as non-congregate shelter and respite care when we were able to purchase the building and close on the property, while simultaneously working on developing housing there one floor at a time. So it's exciting. I'm hopeful that we'll make it into the second round, but that's an example of the type of collaborative project that can happen. And really, the city has been pursuing this from the get-go of trying to buy this other property. So
Yeah, thank you, Andrea. And thanks to Corvallis Housing First and Andrea Myrie for stepping up to be the lead applicant, because it also wouldn't have happened without you. That was a key component. So thank you for that.
I also recently passed thanks along to our board, because they are enthusiastic and happy to take chances and risks. And so I made sure to thank them from you all too.
Good. Any questions? Or Peggy, did you want to make a comment? No. Thank you for CSC's role as well. The CSC, the COG, Samaritan, IHN-CCO, Corvallis Daytime Drop-In Center, our grant writer, Libby. This is an example of that coordinated homeless response coming together to work on system improvements like this. Any questions about Project Turnkey 2.0? And Anita is saying this is absolutely true. Okay, in order to give IHN time to have all their teammates join us and get ready, I'm going to take a 4-minute break, and we will come back at 4:55 and start with IHN's component. So I'll see you in 4 minutes. Thanks, folks. Melissa, Charissa, and Paulina, how are you doing? We all here and ready?
It looks like we're all here. Charissa and I are going to do a combined presentation, and then I think Paulina has her own. So did you want to start with Paulina or Charissa and I?
Boy, that is up to you. I'm just going to pull up this slide and introduce you, and then you can decide what works best for you.
You guys go first.
Yeah, actually, Paulina's gonna a double team IHRI with you, Melissa.
Oh, good. Kind of just tag on to that piece.
Yes.
Okay.
No, we have the same slides that we're all working on though. So yeah.
Okay.
Okay, well, welcome back to the meeting. I hope you got to stretch your legs. The educational component for this HOPE meeting is about Intercommunity Health Network Coordinated Care Organization. We often call it IHN-CCO, Samaritan Health Plans, and IHN's Research Institute, IHRI. You all know Melissa, and welcome tonight, Paulina and Charissa, and I'll let you introduce yourselves, and then I'll stop screen sharing. Charissa,
Great.
you go first.
Sure. Hi, everyone. I've been here a few times. Charissa Young White, she, her, hers. And as it says on the slide, I'm the Medicaid Engagement Manager for IHN-CCO.
And I think most of you know me. Melissa Isaboran, Assistant Vice President for IHN-CCO Operations. And that is, underneath the umbrella of Samaritan Health Services, which I will explain. So I can share my slides or?
Sure, let's go ahead and let Paulina introduce herself and I will stop sharing.
Yeah, so I'm Paulina Kaiser. I'm the Director for Research and Evaluation for Samaritan. So I work for, so I don't work for Samaritan Health Plans. Maybe that's where to start for now. And I think Melissa's going to do a good job of explaining like what it is. Yeah, Samaritan's complicated, but I work for Samaritan. I do research stuff. I know I've been following the work of the HOPE board for a while and have worked with some of the members and with Julie in various capacities over the years. So I appreciate the opportunity to be here though. So thanks.
Can I also say that, Anita Earle's team and the homeless resource team and outreach, Paulina worked hand in hand with them to understand what was the impact and look at really from a data perspective, what were the, how many people were served and helped. And so you all know Anita is one of our key board members. There are connections there that have been long running. So go for it, Melissa.
Great. I will share my screen. There we go. So are you all seeing my screen?
Yes,
Okay,
we
good.
are. And if you could put it in slideshow mode, it'll make it a little bit bigger for everybody.
Yeah, I'm not sure if I'll be able to see you in Zoom. Oh, yes, I can. I'm good. Okay. So really what we want to do is answer some questions that Julie kind of gathered from conversations you've all had as to what would you want to know from IHN-CCO. So really just kind of identifying who we are, how we touch population health, and what are those funding streams and what are the parameters around those that we use to fund different community initiatives. And then the other component that we wanted to provide today is a little more information on the Intercommunity Health Research Institute, which is a newer effort. So kind of getting to who we are, the Samaritan Health Services umbrella encompasses all the hospitals and the Samaritan hospitals in Lincoln, Benton, and Lynn counties. There are also primary care providers, specialty care providers, and so we have the Samaritan Medical Group, and then we have health plans. And under health plans, we have we do provide Medicare services, and we provide commercial services that includes us being a self-funded plan for Samaritan employees. And the other big bucket, the primary bucket, where most of our membership is in Medicaid. And so that's the Intercommunity Health Network Coordinated Care Organization. So in Lincoln, Benton, and Lynn County, the regional population is approximately 2,068 and 720 is the number we have here. The population that we serve as a Medicaid plan is technically 30% of the entire population across the region. And I think there's some animation here. So when you look at the hospitals and the regional medical center, they're positioned a few in Lincoln, a few in Lynn, and then the primary one in Benton County. And so really trying to spread across. 3 of those hospitals are critical access hospitals, which means they're primarily rural and less than 25 beds, and they get some special funding to keep those operations going. Then we have all of the medical group specialty centers, and that includes urgent care. So what we do as an organization, we were formed in 2012. That was really the time period that the coordinated care model was really formulated, and that happened through a ton of different community input as to how do we want to address Medicaid in the future. And so since then, we've been operating as a CCO. We serve almost 80,000 Medicaid members at this point. And our contract includes the delivery of physical health, behavioral health, and oral health. So a comprehensive stream of health services. But we also are required to provide coordinated care and wraparound services. And we have a requirement and a commitment to addressing population health and health equity. And that's what's unique about the CCO model, is because a lot of Medicaid plans, they concentrate on the health, managing your population, managing the risk. But the coordinated care model brought in this whole population focus. To keep people, off, having to be off Medicaid and out of the ERs. And so what do we need to do upstream to address that? And then as we get members in and they have chronic conditions, or multiple social determinant of health factors that can impact their health, we have coordinated care services that are really robust, and there are some strict parameters around what we do for coordinated care, but really wrapping around the member the services they need to, keep them from progressing into a worse condition.
Melissa, can I jump in just to make it clear to folks on this commitment to improving population health and health equity? That's for everyone in the community. That doesn't just stop at the 80,000 folks who are covered by their health plan. That is for the region, the Tri-County region. And that's what's so interesting about the CCO model, is it's not just healthcare for the Medicaid folks. It's how do we improve things for everyone in this whole community to keep people off of Medicaid. So that's really key. Thank you for that, Melissa.
Yeah, thanks for reiterating that. So with that, that's where we get that ability to really invest in social determinants of health and fund some transformative and work with community partners to do some transformative work in the community, which is the funner part about my job, rather than operations. But getting to work with community partners, helping people. And really moving the needle on, solving issues with social determinants of health and supporting that population health. And I put over in the right, this weighted scale, because operations is kind of operations as normal as a health plan, and those things are really kind of dialed in. But the population health is where there's just such a heavy emphasis on that. And it's a ton of work to be able to pull all of the different aspects of social determinants of health and work with all the partners, ensure you have the right people at the table, and it's never 100%. There's always someone missing, but it's really a lot of our focus at IHN-CCO is really to support that population health. So just some fun stuff, mission, vision, values as part of that Samaritan Health Services. We're all kind of governed by these mission, vision, values, serving our communities with pride and building healthier communities together. So not only IHN-CCO, but our, affiliated, the hospitals and the clinics, so all the providers, we are really wanting to bring in that community focus, that regional focus, and really working with people to make things better, to keep track of our individual healthcare needs and the needs of the community, and help solve those problems. We do have this pride statement where, we're guided by that as employees, like passion, respect, integrity is a huge thing. We have to have integrity in everything we do. Transparency, follow up, really being there for people and our community. Dedication and excellence. So sometimes you'll hear that from us in different forums and presentations as to what's guiding us as an organization. And then our strategic priorities, which includes that service excellence and community partnership. You see it again, and sustainability, not just for us, but for our community partners. So as we think about the hospitals and the clinics, they are part of our umbrella of services under Samaritan Health Services. But what IHN does with Samaritan Health Services is we contract with them to provide services to our Medicaid partners. But the really cool thing about being all affiliated is that we can all work together on these mission, vision, and values, and our strategic priorities. So health plans aren't generally attached to health systems in the CCO world. So we are unique in that respect, that we can work directly with our providers, share data directly with Samaritan Health. So we're constantly like, okay, the other providers, we need to pull them into the fold, but it actually creates some good synergy between the health plans and the providers where there's often a disconnect. And then this is kind of a slide of the makeup of how we work with individuals and groups. And you'll see that the IHN-CCO member is really at the center of this. All down the center and to the right is really the groups that we coordinate and participate in. So we have a community advisory council that includes different members of the community, Medicaid members, and county partners. We also attend, but we do not govern some local committees. So each of the counties has a local advisory committee, and their thoughts and recommendations and feedback kind of go through that community advisory council. So there's representation there. And then off to the right, you'll see the regional planning council, and a lot of that community advisory council feeds up into there. It's bi-directional. We have the counties at the table there, so public health directors in that meeting, as well as Samaritan folks. And so we're kind of setting the stage for things, doing some final approvals, but really a feedback back and forth between that group. So it's kind of a strategy out there. And then off to the right, we have several different work groups, and we have the Delivery System Transformation Committee, which is that community-led forum. Charissa will talk more about that, where we do a lot of pilot funding, and it's really managed by the community. Decisions are made by the community there, and they are taken back to the regional planning council to make some final decisions. But off to the right, we have some equity and inclusion, we have finance, compliance, and quality management. So, and we also have the system of care on the behavioral health, social determinants of health aspect. And then off to the left with the partners that we work with. We work with county health departments, child and family services, behavioral health providers, our physical providers, health providers, and dental care organizations. And then of course that bottom right gray bucket, hopefully you can all see this, it is pretty tiny, but that bottom right bucket is our community partners supporting social determinants of health and health equity. And then this is just an organizational chart. And so IHN-CCO, the health plan staff, is really separated into these 4 buckets. We have our clinical services, and that's utilization management and care management. There's healthcare quality in there. And then we have a finance department, and our operations department is primarily project management, customer service, and claims, billing, and processing. And then on the right is the strategy department, and that's where kind of leadership and strategy for each of our products, which would be the Medicaid, Medicare, and commercial products, really sit. But within that, and highlighted in green, we have this IHN-CCO engagement and operations. So very specific to Medicaid, focusing on driving care for our members according to requirements, policy, and community needs. That's where we work on the regional health assessment, the community health improvement plan, where we pull everyone in for input. And then that drives a lot of our work. It drives all of our work, really. And then we also have this engagement arm, and I'll talk about that in just a minute, but that's where all of our community work is done. And I look at that group as a dream team just because it's where I sit. But we do a lot of amazing things. Then at the bottom, we have these delegated services where, we're working with dental care organizations to provide the oral health, and we have oversight and care coordination that feeds into that. But that's all our dental care providers. And then we have a pharmacy benefit management company, non-emergency transportation, and our health risk assessments are partially delegated to another organization because it's a lot of work to follow up and do those calls. So anytime a new member comes in, or there's a triggering event and we have to reassess someone to see if they have a need for care coordination services. So we have a little bit of that delegated. But then we have shared services, and that's where the whole Samaritan Health Services comes into play. And so we share information systems and services under that realm, some administrative services like the HR, marketing, a lot of provider credentialing goes through at the Samaritan Health Services level, and then privacy and compliance. And Paulina, to kind of talk about her role a little bit, we sometimes leverage, as IHN-CCO, we sometimes leverage some of our shared services resources. And we were fortunate enough to have been able to work with Paulina on a number of different things. So we have pulled her in kind of on a permanent agreement where she can help us with her expertise on our Intercommunity Health Research Institute work, and also with the regional health assessment that we do. So, so we get lucky in that aspect as well. And, Anita Earl sitting in the Care Hub, which is part of the system. We also have, great connectivity with them as well. And we're all kind of collectively working towards, common goals. So then this is the IHN team where we really do focus on driving strategy Again, it's a lot related to where policy and directions or directives lie. So what's coming down federally, what are the state requirements, what are the shifts in those requirements, and how do we keep up with them and integrate them into our operations. And then we do have our engagement team. So on the left, you'll see Charissa Young-White, who is on the call with me today, and she has a team of wonderful individuals. One is Sadie Peterson, our Community Engagement Program Manager. We have Beck Fox as a Health Equity Liaison. We do have a traditional health worker liaison that we had only had a half-time person working on THW stuff, which is quite robust, as there's training, there's support for community-based organizations, there's value-based payment contracts, how we get those folks funded, and so a ton of work in that realm. And then we have a tribal liaison, and then also a member advocate and communications coordinator, which is just, it's a new role. And so that one we're really developing, but it's a space for that member engagement and really taking care of the member when they're just at their wits' end and really need help. And then the operations folks, which drive a lot of change operationally in how we work with our members, how we implement new policies. And there's a lot of community collaboration with our community partners, our practitioners, and also at the state level. So within these two teams, and a lot of the individuals on the team are very cross-functional. They have various skill sets that apply in multiple aspects. So we really have this great synergy on this team. And on the right, we have, our operations manager. We have Danae Wallert, who works on benefits, and Tristan Armstrong, who will actually be moving over to our member advocate role. So you may hear of that individual's name coming up in the future. We also have general project manager and an HIT project manager, because everything we do is related to technology. How do we track it? How do we coordinate and share data? How do we pay individuals, providers, and get our grant funding? It's all technology, right? So emphasis there. So our contract, we have a 5-year contract. So it's usually a request for application. We do our application, you get approved, you get a 5-year term, reinstated contracts every year. So minor adjustments are made. But that really includes the physical, oral, and behavioral health coverage, the general services, which includes care coordination. And then we have a value-based payment component. That's a whole section of the contract, and how we pay our providers for value-based care rather than fee-for-service. So promoting outcomes, grievance and appeals. And then we have these two sections that are pretty heavy in requirements and expectations. And so you can see just by looking at the contract, which if you click on this link on the top right, ever want some light reading, there's about a 300-page contract in there. And we all have to know it by heart. So we have a couple of different sections, one on social determinants of health and one on behavioral health. And the behavioral health is actually more expansive than what are just the covered services and how we manage those in the contract. So it's really kind of interesting. But yeah, that's separated out into two contracts that basically cover the same thing. And one is just the general Medicaid Title 19, and then there's the Cover All Kids, which is the federal Children's Health Improvement Program, health insurance program. So with population health and health equity, we are really working as an organization to make those efforts more robust. I think what's happened in the past is we had some turnover. And as we've had that turnover, we also experienced the COVID-19 pandemic. So it really brought to light all the issues. So we were doing a lot in the population health space. We've been funding pilot programs for a long time. We had a population health department, but it's just really it really come under the microscope, and there's really been greater emphasis on we need to help our community. And yes, that includes more than just Medicaid members. So we're working on better understanding our populations. We have a great population health data tool. Integrating social determinants of health and health equity into our decision making. So how do we look at data through a health equity lens and solve problems from that perspective rather than in the aggregate? And then a lot of it is collaborative partnerships, which is really what we're doing here today. Like, we need to be engaged with the community. We need to know what's going on in the community. We need to know the barriers, and we need to work with everyone to collectively figure out how to solve problems and support efforts to solve problems. So really a lot of emphasis here on population health and health equity. And that's one of the most rewarding things that I do in my job, because I can, spread, some funding around, help individuals with strategy, help address barriers, help identify barriers. And the more contact we have with individual organization or individuals in general, the better informed we are, and the better we can connect people together to solve problems. So that's it for my piece in terms of an overview. And Charissa Young-White, an amazing individual, wealth of knowledge, has been doing a lot in the population health space for quite a few years with IHN-CCO. So she's best knowledgeable about how we've been funding things, and has been a part of a lot of the great work and connecting community partners together. So I'm going to turn it over to her, but I think I would like to stop to see if anyone has any questions.
Melissa, do you want to stop screen sharing for a sec so we can see if any of the board members have questions?
Yes. Did it pause?
I am still seeing your screen.
Okay.
There we go. Okay, questions from our board members about anything that Melissa covered. Barbara, go for it.
Hi, thank you, and thank you, Melissa, for that.
I can't
Barbara,
hear.
can you speak a little louder or move your microphone closer?
Sorry, hang on just a second. Yeah, I've been having technical problems all day long. Is that any better?
It's really soft. You will have to talk very loudly.
Okay, you know what? I'm going to put it in the chat.
Great idea.
Thanks.
And maybe, Barbara, is it okay if we wait until after Charissa goes, or is this a should answer right now? And one thing to note from the chat, Paulina is in research and development, and then Anita's Care Hub is also over there as well. Okay, well, let's go ahead and dive in. Oh no, here we go. Here's her question. Is the Research Institute under the engagement group in the org chart?
It is actually just under that IHN team. So basically, a lot of the work happens out of the engagement group, but it does bleed into operations in some respects when we think about grants and structure and coordination. So, but essentially, yes.
And we'll talk more about the Research Institute after Charissa's piece. So more to come.
Awesome. Go for it, Charissa. Let me know if you have any issues screen sharing.
No problem. I think Melissa would probably just bring them back up, but I can if you want to. Yeah.
I'm going to bring it back up for you.
I will comment. I'm going to follow up quickly on Melissa's comments here. I have been with IHN-CCO for, I did take a short hiatus, but for quite a few years, and really happy to be with IHN-CCO and the leadership. But Melissa said some nice things about me, so I'm going to shoot it right back at her, because Melissa started just about a year ago, I think. Actually, it's less. It was actually right when I left too. We only crossed over for about 3 weeks. But she was one of the biggest reasons why I came back, because Melissa is really driving population health and health equity for IHN-CCO. And I think she's a big reason of why we're here today and why we can talk about a housing strategy and really work to collaborate together. So I'm really excited to be part of the future of IHN-CCO. So anyway, okay. So talking about funding streams, this is a lot of fun for me. I absolutely love what we do on community benefit initiatives. And the best part of my job is literally half of it, at least at this time of year, is giving away money. I mean, I don't make the decisions, but I get to like make the contracts and do the technical assistance and support people who want to fund projects that are primarily community-based organizations and social determinants of health and equity partners out there that are on the streets, that are out and everywhere, not just the streets, but rural areas, urban areas, supporting our members. So it's really exciting work. So a couple just quick overview on our funding streams, though. We do have what is just called Medicaid Dollars. So this supports the medical, behavioral, and oral health activities for the most part. It does include care coordination and connection to resources, like it says on here, but it's really trying to manage healthcare. We're getting more towards the whole person, but it's still a little bit more focused in this medical, behavioral health, and oral health model, right? But health-related services are really to look at the entire community as a whole. What does improve the health and the well-being of our community? It's definitely our IHN-CCO members through flexible services. That piece is specific to our members. It is really on an individual basis where any member of the care team can request something that is not technically a covered benefit. So durable medical equipment could be an example there. Air conditioning units during the hot season, related back to a health outcome could fit in there. So flexible service is something that is managed by our care coordination and case management teams, and they have a whole team there. But what we're going to talk about mostly today are these community benefit initiatives. And let's just move to the next one here, if that's okay, because we're going to talk about the community benefit initiatives today that we're talking about is about 28 million in the last 10 years. So this is outside of what the Oregon Health Authority has said fits in these, medical claims expenses. This is what IHN-CCO has chose over the last 10 years to spend on social determinants of health. So the biggest focus is health information, or not the biggest focus, but one of the focuses is health information technology. We also have behavioral health supports. Traditional health workers is a huge focus, almost $6 million. And these are the funds that IHN-CCO, they're not in-kind funds. They're not funds, spent on hiring a traditional health worker liaison, things like that. They're funds that are spent out to the community that are given to our community-based organization partners. And then the one, that we want to talk about today really is this $3 million spent on housing, which is increasing as we go, because we now have 2 different funding streams under this community benefit initiative umbrella. So if we go to the next slide here, and you'll get these afterwards too, if you want to review them in more detail. But one of the ways that we fund, and that 3 million came out of this, is the Delivery System Transformation Committee. So I think some of you here are on that committee, which is really wonderful. It is a community-led and community-driven committee that chooses priority areas every year based on our community health improvement plans for the region, especially our Community Advisory Council's Community Health Improvement Plan. And the reason I bring this up is I want to call out that we do hear in those local committees that Melissa was talking about earlier and the Regional Community Advisory Council, we do hear from our members. We ask them to set priorities and to tell us what's important to them. We take back that information and we do use it in our funding streams for getting our funds out to the right places in the community. Through the Delivery System Transformation Committee, we have over 60 community partners. I think that's over 75 now, honestly. And when I say like over 75 partners, I don't mean 75 partners have showed up one time in the last couple of years. I mean, they literally are showing up every 2 weeks to these meetings and or showing up to one of our monthly hour-long work groups around health equity, social determinants of health, the Unite Us Connect Oregon platform, our sustainability work group, and then of course, traditional health workers. So this is a really, really exciting committee. If you're interested in joining, please let me know. It is open to anyone that can positively impact the health outcomes of IHN-CCO members. But I think we should not really focus on that. It really is community members. As we have worked through our charters in the last few years, we really are talking about community benefit overall and population health and equity.
And Charissa, I remember the last one I attended in person in that sort of sub-basement enormous room with 10 different whiteboards. There were probably 50 to 60 of us there, people who do supported housing, creating housing coalition, people who are out there helping folks in need, being able to write down what the priorities were and give that feedback. I can't wait to do that again in person.
That was fun. And that was in the basement at the Walnut Building. My goodness, that brings back memories. That was a good time though. And that was really exciting. I think Peggy McGuire was there too, if I recall. That was in 2019, I think. And I'm going to go off on a tangent on that because it's really interesting. So that was the Social Determinants of Health work group. And we invited all of these folks around the region to brainstorm and help us understand how we can do better in housing. It was really specific to housing initiatives. And what arose from that is this really beautiful recommendation document from this work group on where IHN-CCO should be putting their funds around housing. And where we landed because of that document was around medical respite, the lack of medical respite beds in the region, and housing supports, traditional health workers in the housing sector. And so actually, Melissa might not be there, but we can go back a slide in just a second. There's another, sorry, could you just go back one? This was a good tangent that Julie sent me off on, so I'm going to keep on talking about it. This $6 million of traditional health workers on the right bottom here that we've spent on social determinants of health, a good portion of that, I don't have the actual amount though, is on traditional health workers and navigation supports in the housing sector. So we supported some programs based on that conversation to really help get our members connected to housing, but also connected to other social determinants of health. Through some of the pilot programs that we funded, we've been able to see a reduction in evictions prevention, or a reduction in evictions, improvement in eviction prevention rates, I should say. We have also seen an increase in preventative care and a decrease in emergency department utilization simply by providing wraparound type supports in the housing sector. So really exciting work there.
Can I give like a tangible example for people who are hearing all these sort of like high level policy words? Would an example be like paying the salary of the person who goes on site to affordable housing units that Dev Northwest owns to help those residents on site, making sure they're getting their doctor's appointments, any kind of education, transportation, financial help and wraparound support? Would that be a tangible example of what you're talking about?
Absolutely. They were one of our first pilots back in 2017 that was funded in the housing sector. So thank you. You're helping my presentation just a ton. That's wonderful. Giving it some contextual feelings. I really like it. So I appreciate that. Okay, so let's skip ahead. I think 2 slides now. Actually, no, back up one. Apologies. The Delivery System Transformation Committee, the request for proposal that we are currently in this cycle for this year is closed now. But I want to just mention, in future years that we almost always have a request for proposal. There's no promises or guarantees. So next year, there will likely be another one in spring. The last couple of years has been a huge focus on housing, on workforce development, on increasing access to culturally appropriate services. Behavioral health is always a priority area for the DST, at least for the past 10 years. So just think about if you have any really innovative and transformational projects, that the DST might be a place to come for that. So joining as a partner, you can network and connect, but also through the RFP, there's a possibility for funds as well. So currently we're reviewing about 19 proposals in those areas. So it's really exciting. Okay, next slide. So this one is really specific to housing. This is our supporting healthcare for all through reinvestment. I'm going to call it the SHARE initiative from now on, because that is a mouthful. It's a brand new regulatory requirement in 2021 from the Oregon Health Authority. And what they asked of us is to take some of our savings, what would normally go into sort of a reserves bank account, to take some of that and reinvest it back in the community on social determinants of health. So we're required to fit into certain buckets. So education, social and community health, neighborhood and built environment, and economic stability. And one of the other areas that is required is housing. So what IHN-CCO decided to do last year, and again this year, is to focus on housing. So again, based on the social determinant of health work group work, based on our community advisory councils, community health improvement plan priority areas, the recommendations that folks like you all have provided to us, we really recognize that housing, it is the place, it is the high need right now. So last year we funded 6 social determinant of health and equity partners out of our 7 projects funded. The other one was increasing the number of care hub staff to support medical respite for IHN-CCO through.
And Teresa,
Yeah.
Care Hub staff is Anita.
Right.
I wondered actually if Anita might be able to like chime in with a real world example of how this investment changed your team.
Yeah, I was chomping at the bit to do so. That's so funny. Care Hub is Anita. Not any longer, but that is the origin story. So the homeless outreach efforts began about 4 years ago with a grant. And then Samaritan, we saw from the work group, right? We saw that the unhoused were in desperate need. And so we got a grant to support me. And then that has now grown and been grandmothered in from Samaritan. So there are 3 social workers that work for me, and we have this robust team of nurses and community health workers that grew out of this origin story of we've got to help the unhoused. Housing is healthcare. How do we navigate that? And I will also add for you, Julie, that I currently have a DST proposal in. Right? And that proposal that I completed with my boss, Glenn Cunningham, is what I've discovered over the last 6 months is, although I have many respite beds in the Tri-County region, there are many folks who are facing death and dying, end of life issues. And I've been desperately cobbling together how to care for those unhoused folks for the last 4 years. And the brainchild, my brainchild was, I need a hospice house bed. And so we have a current proposal in requesting help in paying for a bed at the Evergreen Hospice House that could be used exclusively by the unhoused to restore dignity, end of life. So there's a little something.
That's wonderful to hear, Anita. Good luck with your proposal. Another example of how this just overlaps with all of the HOPE work, Glenn and Anita met with the Project Turnkey team to say, you know, if you're able to acquire a hotel, we want to support medical respite beds at that location so that we can transition folks who are getting discharged from the hospital and who are experiencing homelessness to a safe, stable place with support on site. And that's where we're really working to coordinate all of this together. So thanks.
Thank you. And I'll comment, I did technical assistance with Glenn on the end of life support pilot proposal. And it almost brought me to tears hearing some of the stories of folks that were out there and literally dying in cars and on the side of the road with these needs. And so I am a non-voter at the DST because I support overall. I'm very neutral and I will not comment on any of the 14 proposals left for decisions on. Actually, we approved 5 small ones last week. That will come out and you'll hear more about that soon. But the 14 that are left are all very good. And so if I did talk about this with Glenn though as well, there's a couple of them that are around housing. So should the community driven and community decision makers at the DST decide not to fund some of these that are related around housing, we can go to the next slide. This is going to be a really nice segue into, they can apply through a request for proposal through the SHARE initiative. And it's not going to be any extra work from them, except I might ask them to change their header or something to say we're applying for SHARE. I don't know. But lucky for me, I get to kind of manage both with Melissa. So we can say, hey, so the application process is going to be super easy. It's really just going to lift and drop over here into this housing request for proposal. Again, this is on medical respite. I really feel like that hospice could fit really either in medical respite or navigation supports, at least indirectly. So I'm pretty sure that one will fit. Really, we look through the request for proposal that as long as they fit that priority area, they are accepted for review, certainly. And then we look at different components here. I'm not going to go through all of these, but whether they have a strong health equity plan, are they reaching historically marginalized communities, communities of color, disabled folks, who are they reaching? Sustainability, we kind of talked about that earlier in the conversation, so I'd love to bring it up again. We have different components around sustainability that we want to look at. So we are doing, financial sustainability. Are the funds going to continue? But we also talk about scalability and replicability as well. Can we spread these promising practices? Can we move to a different organization, a new region? Can we move from, maybe a Benton-centric proposal to a regionally centric proposal? So let's include Lincoln and Lynn counties, things like that. And then another piece of sustainability is depth of support from the community. So depth of support means that, do you have organizational support that if funding were to decrease, is there support around staffing that could really go look for grants and do other fundraising? Is there community support? Does the Hope Board say, yes, we want this, we have to have this, this fills a gap. We really want to hear from our community around this. So these are the other pieces, and I'm really happy to pause, especially on this piece, because I really think there might be some interest in this group. So I'd like to pause here and see if there are any questions around the process or anything.
Would you like to stop screen sharing to see folks as they're asking
Sure.
questions? You have one question in the chat already. Charissa, is there an increase in available SHARE initiative for 2022?
I believe we have around 700,000 again this year.
Any other questions from folks? I can't see you all, so go ahead and just chime in. Okay, I'm not seeing any. Charissa, if you want to keep going.
Absolutely, and I'll just comment that we will send out the request for proposal. It's really just going to look like this with the application documents that you'll need to submit. And then you'll be asked to meet with me and a couple folks on the team to do technical assistance, because we found that's really helpful through the process. So, but you will get the announcement of that for when we are accepting proposals. I'll make sure that Julie gets that and sends it out to the entire group. So, okay, next slide.
Yeah. I would say the great thing about these two different funding opportunities is we tried to simplify them as much as we could. Just a simple proposal. We need some outcomes attached to it. We provide that technical assistance. And we've had community partners say, I would have never come to try to get funding or grant funding, but it was so easy. You just pulled me along the whole way. And then these individual organizations get to present their ideas, and a lot of times they make connections with other community partners that want to join in the effort and have complementary services and goals. So it is really a nice way to do this.
And it's fun. Like Melissa said, this is the fun part of the work. It's really fun. So I think we're getting close on time. I want to make one more comment here because I want to leave time for the IHRI, which I think is really interesting. But the difference between the two, one of the major differences is the DST is really about innovation and transformation. And SHARE can be innovative and hopefully transformative, though, is really about what is working, what do we know is working in the housing sector, because that's our priority area, and how can we just keep on building up that infrastructure. It's not about making brand new projects. It's really about building on what we already have. Okay, next slide. Oh, great. Yes. So I wanted to talk a little bit about the housing strategy. So Melissa and I are working with Stephanie Jerome, who's on the call. And Stephanie, some of you might know her as Stephanie Jensen a few years ago. She worked with IHN-CCO and the Transformation Department. So Stephanie is really providing a lot of support through this housing strategy. We're all working together in a collaborative way, but Stephanie is really a full-time employee and consultant, but a full-time person, I should say, that is supporting this trying to convene on a regional level of the funders for housing, developing tracking around these different funding streams. So she'll probably be reaching out to meet with you folks, a lot of you anyway, in the next few months. She just started a couple weeks ago, so this is all brand new to us. We'll be talking about what kind of programs can IHN-CCO help support. What can we help to do to collaborate throughout the region, so Benton, Lincoln, and Lynn counties, to ensure we have regional strategies that are aligned with the gap areas in the particular counties as well. So we also recognize there's differences in all three counties, and the needs may be different. Actually, between counties, the needs could be very different between Albany and Lebanon, for instance, but really at least taking a sort of more of a bird's eye view over the region and saying what strategies can we at least collaborate and learn from each other on. So this is a really exciting piece here. So Melissa, do you have anything else on this? And then I think I'm all done and can turn it over to the IHRI.
No, thank you.
I just wanted to make a connection for our HOPE board members. One of your foundational recommendations, I think recommendation B, was to figure out how to better fund how we help people and transition them out of homelessness in a sustainable way. And also part of this pilot that the city and county are embarking on includes a strategic plan that addresses sustainable funding. And so we're going to be doing a lot to coordinate with Stephanie and Charissa to make sure that we are leveraging and having collective impact instead of duplicating the effort that they're putting into this. So plugging into their process to map out sustainable funding instead of trying to duplicate it just for Benton County. So just an example of that kind of coordination.
Thanks, Julie. So to talk about the IHRI, the Intercommunity Health Research Institute really grew out of a desire to look collectively at all the work and all the programs that are happening in the community and the total cost of care, just anything you can think of to really determine what's working in our community. How are we addressing population health and the needs of our community and health equity? And how are we communicating that to everyone? How are we then leveraging that good information to put efforts into programs that are successful and expand on those, provide information to our community about those resources and the work that's been done? And so really honing in on a research and data aspect as to how it can inform our community and our investments in population health and health equity. So what we did this year, we established that research institute under the IHN-CCO umbrella, and we pulled in a bunch of key kind of stakeholders and partners. And one of those is Oregon State University. We have a few folks on the governing board for that, the governing committee. From OSU to really bring some academic rigor in that evaluations. And then we do have several community partners, including individuals from Samaritan Health Services in the provider space, but also community-based organizations and like the Regional Health Equity council. And we also have two senators, Senator Anderson and Senator Gelser-Lewin. And we also have Commissioners Zan Ojero. So we have quite a robust group of individuals with varying priority areas of their own to really inform the work that this research institute does. So it really started as a concept. We have some short-term goals and long-term goals, which I'll talk about later, but the upshot is we really want to do that evaluation and research, making sure we're putting into those research and evaluation efforts and the idea of what our community partners and our community members really need. And how do we address those needs, and just making sure that it's data driven. And we really want to leverage some grant funding to be able to do this work ongoing. So starting with some smaller grants and then moving into some longer term grants. So we're really doing this following our collective, the collective impact model in general, just making sure that we leverage that shared vision for change and measure our outcomes, and having that consistent and open communication where we're building that collaborative partnerships, we're listening to one another, and then having this backbone support. IHN-CCO is a regional partner. We don't operate in just one city and one county. We really look at it from a holistic perspective. So Teresa talked about that as, if someone is doing something in one county, can we look at, scalability, look at offering it in other counties, other cities. But we have funded the IHRI with some initial seed funding and hope to pull in grants to do greater scope research and evaluation. And what we want to do is, again, kind of communicate that out and have that shape, that information shape what we fund as a community. So just leveraging all the existing work. And really it's interesting. We just had our I think it's our third or fourth meeting that we just had. We started this institute earlier this year, and we've been talking about priorities, and we're moving into strategic planning. And one of the things that they really said is, in their priorities, we want to leverage the existing community resources, find the gaps there, do not create any existing infrastructure. And that's very true, because everyone's doing these great things in pockets, and how do we just support that and make it better, make it more sustainable and robust. So really interesting.
Melissa, just a time check. There is 10 minutes left in the meeting.
Yeah. Okay, great. Yeah. Sorry, Paulina, I'm done here really. So really we have the short-term goal of doing some smaller activities, starting with a delivery system transformation evaluation, looking at the outcomes of all the things we funded in the last 10 years, and then that getting into that more robust research and education. So go ahead, Paulina.
Yeah, thanks. I feel like I don't have a whole lot to add other than to kind of voice my enthusiasm for IHRI. And so I think, again, going back to kind of like the structure and who's who and who does what. So to clarify, IHRI is kind of based on a novel internal collaboration first, which is bringing IHN with Samaritan's existing research infrastructure. So I've been at Samaritan in the research department for like 6 years about, and that role has been a lot of working with clinical data. So a lot of understanding EPIC, Samaritan's electronic medical record system, and doing various kinds of research and analysis projects with EPIC data. But it so happens that like my background and my true kind of passion and area of interest is in public health. specifically epidemiology, specifically social epidemiology, which is the kind of subfield that focuses on understanding how social determinants of health influence population health outcomes. So when I came to Samaritan 6 years ago, I did not anticipate that this opportunity to work exactly at doing analytic projects to understand how social determinants of health influence population health outcomes. I did not see this landing on my lap as nicely as it did. But Bruce Butler from Health Plans tells this great origin story about how he was down in California at a conference and heard Karen DeSalvo, who was the former head of the Federal Department of Health and Human Services under Obama, talking about how health systems, the health system generally needs to get on board with social determinants of health. And public health has been talking about social determinants of health for literally decades. This is not a new concept. It is a very new thing for health systems, and it's a very hard thing for health systems to operationalize and implement and integrate with all of the other partners that have been doing this work for a long time. So I think Bruce was really the original motivation for trying to what would it look like for IHN as a from a health payer in a state with the CCO model where OHA is really pushing the CCOs to be really innovative and literally transform what the health system is, what it means to pay for health services. We have, it's a great context. There are a lot of kind of environmental external pushes to really help IHN think about what it means to address and intervene on social determinants of health. And so when Bruce kind of first talked to me about this, I was like, yes, please, where do I sign? Yes, this is awesome. And so just to kind of share where that's coming. So a lot of this, the kind of research and evaluation emphasis, the data analysis piece is kind of a new thing for IHN. I've done a lot of work with Epic data, with the clinical data. I've never worked with claims data before. So there's kind of just to share that there's a lot of internal learning going on in terms of what the data looks like and how to work with the data. But I think as Melissa mentioned, that the community integration and the focus on community priorities and being also then to leverage the collaboration with academic partners as well is also really kind of foundational to the structure of IHRI. And we're just getting started with all of this stuff, but I think there's a ton of potential and yeah, I'm super excited. And I think there's a lot of opportunity with kind of better using the data that we have from, Samaritan's got oodles of data that we're not really using. So that, that's on me to figure out how to do that. But I think, anyway, just as an example that there's a lot of opportunity of things that we can do with better kind of alignment and coordination of resources.
Can I make one connection there too for folks who don't know? So Bruce Butler, who works with Melissa and is one of the heads over at IHN-CCO, he was on the HOPE board for the first 2 years and then passed the torch to Melissa once she came on board. And so Bruce was a part of the whole process of figuring out what the needs were here and creating the HOPE board recommendations. And now you can see the result of that work and the result of the HOPE recommendations with these investments in improving all of these different systems. So I want to give Bruce some credit. I must have emailed him every week with a different article about how healthcare is paying for housing, that poor man. And so I have to give you all a lot of credit over at IHN. I have seen more stepping up to the plate in the past 2 years and wanting to coordinate and collaborate and invest on this topic. So thank you for that.
Yeah, we'll pass that on to Bruce. Yeah, as our CEO, he's super supportive of all of these efforts, which is really good because a lot of times you don't see that in leadership at health plans. It's yeah, population health is great, but Bruce is there yes, do it. Yes, do it.
Well, and he was on work groups with Andrea Myrie, hearing directly from Corvallis Housing First. Here's what we need from you as a health provider. So yeah, we'll go to a couple minutes of questions. George, you've had an opportunity to ask a couple before. Are there other HOPE board members who have a question? And then I'll go over to George. Okay, go for it, George. What's your question?
not as much a question as a comment, that it's nice as somebody who's, and a number of people in this room have been in this field for a long time, and as long as I have, and maybe a little longer. And we've seen that how government has dismantled the human service delivery system over the course of our career. And it was always pushed back down to the local level. Funding was decreased, and it was pushed down, decision-making down to the local level. And this is a result of that in a good way, because it's forced communities to be able to say, what are ways that we can come up with to support that infrastructure to deal with things that are significant problems. And what we're seeing here is a system being developed and being re-amplified. And what's different now than times in the past is there's money involved with it. So they do have, there are funds that are available. It's backed by the ability and rules that allow it to be able to go out and find what's the most creative way, what are the efficient and creative ways, what's needed at a local level. So it's refreshing to see this, and it's really, I understand their excitement and enthusiasm, because this is how you turn policy into reality. And you have to be able, if you're an elected official or people that are allocating money, you have to be able to say, we're making sound decisions, and looking at indicators of health and then other data to back that up is a really good way to say, if we invest money in this situation, we can expect to have positive outcomes. So I commend the work you're doing. Keep doing it. It's great. It fits with us. We're all in the right place at the right time here.
Thanks, George. And thanks everyone for all the wonderful comments in the chat.
Thank you. Is there any last question from our board members, or comments or feedback? Well, thanks to the IHN folks, you saw a lot of the feedback in the chat, so it has already been given. Lots of thank yous for being here. And I will follow up with the HOPE board members and share your contact information if they have follow-up questions. And we'll also include all of the slides that were shared today on the HOPE website. They should be posted by next Wednesday, along with the video of this meeting.
Great, and thanks to Teresa, Paulina, and Anita Earl for all of their expertise and the context provided today. And you all are definitely the key individuals making this stuff happen on our end.
Thank you. I have one last slide to share with folks just for some next steps, because I know people appreciate that. Our HOPE implementation team, we're working on the pilot MOU. We're working on data improvements like coordinated entry with our provider partners and care coordination, like the implementation of Fuse in partnership and collaboration with IHN and their work on that and the situation table. And then at your next meeting in August, the executive committee has invited Sean Collins and Andrea to give an update on Project Turnkey and the 3rd Street Commons. What is housing first? And I'm going to be reaching out to any of you as board members who have shared with me that you have lived experience with homelessness and housing insecurity. There's been some interest from board members already in sharing that. So having the opportunity for any board members who want to talk about their experience. And then in September, we will have our county community health center folks come because they do similar but different work that IHN and Samaritan do, because our CHCs are federally qualified health centers. So they help all folks, people who are uninsured or undocumented, and they do support a lot of people experiencing homelessness in various ways. So learning as a community, now that you've learned about what IHN and Samaritan do, also learning in September about how the county health centers work on these different topics. And I think that was it. I will stop sharing. Any last minute questions, folks? Okay, what a great meeting. I learned so much. Thank you all the IHNers for being here. And thanks to our HOPE board members for the wonderful questions. See you soon. Take care, everyone.
Thank you.
Thanks. Bye.